Today I'm meeting with the wonderful Robin Spiro coming live from New Jersey. And before we begin, I'd just like to do an acknowledgement of country. So that is to recognise the traditional owners of the lands that I live and work on, the Whadjuk Noongar people. Welcome, Robin, and thank you for being with us in this evening of yours.
So delighted to be here with you, Nadine, to share our common interest.
Yeah, I mean, this is one that I'm quite excited about. I mean, I love meeting with all the schema therapists, supervisor trainers, but this is an area that I have spent years studying and becoming more and more interested in terms of the multiplicity of personality structure. So it is a great thrill for me. So I'll just spend some time introducing Robin. For those who may not know her well, Robin is an advanced schema therapist, supervisor trainer. She's based in New Jersey and she's been practicing schema therapy for more than 20 years. Robin originally trained as a family therapist and has since also trained in EMDR and internal family systems. Robin developed a comprehensive training on complex trauma and DID with Judy Margolin and Megan Fry. And that's a wonderful training. I've participated in myself. And she also regularly runs complex trauma and DID supervision groups throughout the year, of which there is one running in an Australian time zone. And Robin also offers more general supervision, but that those groups can be made specific to other time zones in Europe and the US as well. Also, Robin is currently the chair of the ISST Supervisor Skills Development Training Program. So welcome, Robin. That's really a wonderful list of things that you share your expertise with in the ISST community.
Thank you for the lovely intro. I'm so happy to be here to discuss this topic.
Yeah. And so I thought it might be nice if we begin by talking about how you became a schema therapist, because as you mentioned in your intro or your bio, you were a family therapist to begin with.
Yes, I was working in a family therapy agency, and unfortunately, the agency went through some changes. It adopted a very behavioral short-term model. So I was seeking to join a group private practice where I would continue my training. I had the very great fortune of being hired to a group practice with Wendy Bahari. And I was trained by Wendy in schema therapy in the late 90s. She likes to say we were both 15 at the time when we met. And for years, in addition to the training, for many years, we had meetings every Wednesday with schema therapy colleagues. So it was a fabulous ongoing group schema therapy supervision situation. So I consider those people my schema therapy family, right, and very fortunate.
Yeah, and so now it makes sense to me how you've been a schema therapist for so long, because obviously with Jeff being and Wendy being so closely linked in developing the model, and then you end up working for Wendy Bahari. So yeah, that's great. And so you're really well known in the schema therapy community for this interest and expertise in complex trauma and DID. How did you come into the world of complex trauma and DID?
Well, when I worked in the family therapy agency, we had contracts with the Child Protective Service Agency, and we were referred cases of child sexual abuse, children and adolescents, and provided training to deal with those children and adolescents. And then as I worked with them, lo and behold, I learned that their parents and guardians also revealed to me backgrounds of sexual abuse. And so I sought additional training in that area to work with them. And then after being a schema therapist for a few years, the psychiatrist said, I want to refer you someone who's a really difficult patient. She's intractably depressed. I cannot help her with her depression. So, and at that point, this was in 2001, and I was like, oh, goody, a really challenging case. I wouldn't feel that way maybe right now getting that description. But at that time, I was excited for the challenge. And she was very depressed. She alluded to a trauma background, which she wouldn't share. And I ended up, because she was suicidal, I found her a specialty trauma hospital in Washington, D.C., where after a few weeks, she was diagnosed with dissociative identity disorder.
Okay.
And so I thought, oh boy, I don't know how to treat this. She's coming back to me. So I lined up not one, but 4 consultants to
bases covered.
Yes, from all different fields to educate me. I read a lot of books. I attended trainings and workshops. And then subsequently, that same hospital program referred me someone else with DID. Other colleagues learned and also referred me people with DID. And sometimes people came to me with trauma, and I didn't understand that they had dissociative identity disorder, but it came out as we worked together. So
yes,
that is how I got into this field.
so
I
it
do
sounds
have
like,
oh, I'm sorry,
yeah,
go ahead.
No, you go ahead. What's the
I was
one?
going to say, I do want to say one pet
Mm.
peeve about the diagnosis, dissociative identity disorder. Not that anyone's asking me to revise the diagnostic manual, but I wish we could call it DIA, dissociative identity adaptation, because I just think that for people who've been so incredibly abused and neglected, that some of the most creative, intelligent, kind people I've met have been my patients with DID, which I wish I could call a DIA, because, you know, sometimes other people in their families are much less functional. They might, you know, one of my patients had a sister who was a heroin addict, but my patient was functional because she found a clever way to separate the trauma from her daily awareness when she needed to, and to develop other sides of herself. So I have a lot of respect for my clients with dissociation. I just want to put that out there.
And I really love that. I actually think that the word disorder, and I see it in the autistic community and other communities too, where that's really being rejected and saying, well, this is actually who we are. And I know DID is different because it's come from a trauma adaptation, but it really is. Most things are normal human expressions. They're not disorders. They're normal human expressions to difficult experiences or family contexts that are almost unsurvivable. And so I think that this idea that you have is really wonderful, actually. And even I think some of Janina Fisher's work that I've read too really normalizes trauma symptoms and says, you needed these, or these are doing this for you. You know, so you're not disordered, you're actually having a normal response to something very overwhelming that your nervous system hasn't yet adjusted to, or not that you're going to stay like that. But that's really great. And I'm so glad that you stopped me there with that. I was going to say, it sounds like it is for many of us who develop a strong niche, is it just takes one, and the one requires a lot of work. And it's certainly actually part of the reason I ended up on your course is that I have the one that I've been working with for 5 years, where nothing I did was working, and I couldn't understand why. Like I know how to do a lot of things. Over the course of this career, I've picked up a lot of things, and I just couldn't work out what was going on with this person. But of course, when people have dissociated structures too, they're often really ashamed about it. So they don't volunteer this information in assessment with you. Even if you ask, and even if you give them measures. You know, for example, when I found out about the mid, I have delivered that to some people who I know have more going on, and they'll still fill it in as if those things aren't happening for them. So
it's so true. There's so much shame, I think, because of how the media portrays people with that diagnosis. People just feel such shame and such a phobia about even admitting to themselves that they have that diagnosis. So yes, it does. I think there's research that showed that the average person with GID, I think, has 7 wrong diagnoses before they get the correct one.
Yes. Yeah. So, you know, I think that's part of, for all of us where we end up, but it sounds like, you know, clearly with your 4 consultants, you found a way of doing this. And it was something that because sometimes we get a one-off person and we think never again, but there was something about this. And I think that survivorship that you've talked about there, and that admiration that you felt for the way that people have survived, obviously then led to really developing this further. So I'm just wondering, for those people who are a little bit unfamiliar with DID, if you could explain the difference between a dissociative disorder and dissociative identity adaptation, we'll call it.
You and I will have our own diagnostic manual.
Why not?
Throw the other one out. We'll just go with our own. So, well, to start with complex trauma, many people experience, unfortunately, some kind of trauma in their lives. You can have a traumatic car accident. You can have, in adulthood, you can have, unfortunately, a sexual assault. But when we talk about complex trauma, we're really talking more about a pattern that develops early in life, which may have many unfortunate elements. Any type of abuse you can think of, blame, being neglected, being ignored, not being protected, having your rights thwarted repeatedly, and abandonment may be a part of it as well. So there's really an overwhelming experience from a very early age. So most people with complex trauma occasionally use dissociation because it's just too overwhelming. They may occasionally have to rely on dissociation as a tool, as a way to escape. But we know, as you said, you're interested in multiplicity. Everyone has parts. So the whole spectrum of dissociation, the whole continuum, everyone has parts. When you get to dissociative identity disorder, there are a few distinguishing factors. One is that sometimes the parts have the ability to take over the consciousness so that the presenting client isn't even present. With lesser forms of dissociative disorder, the presenting client, the adult client who you see, is always present, even if other parts are really having a major impact on behaviors and feelings and thoughts and sensations. With DID, I'll say it that way for ease, with DID, the parts are more developed, more multidimensional, and they have their own sense of a personal history, personal preferences, personal relationships even, and they do have the capacity to take over. And to take over so that the main person is gone and doesn't know what happens for certain periods of time. And that's, of course, something that you work towards minimizing and eventually getting rid of that aspect, because that is a dysfunctional aspect of living.
Right. Yeah. It's actually interesting. And sometimes I think my phone can hear me, but on YouTube I was being shown videos, and it was from a channel called Multiplicity and Me. And it's, I think, a woman who's a therapist now, but it was a very educational channel just about her identities and seeing her switch. She found it quite hard to show a switch, but also that her dog would try and interrupt the switch. I think he had personalities that the dog preferred. But it was actually really interesting watching the dog try and keep her in her host, what she called her host. So
yes, that's very interesting.
Switch. And also she does some, if anyone's interested, she does some beautiful description of the blending that can happen. So the DID parts can still try and seem like it's her, but it's actually not her host self anymore. It's the other ones. But and actually I just got another video saying that she's through her treatment and she no longer considers herself to have DID anymore, so she feels integrated, which is amazing. So it was a very long journey, but
but my definition of integration is maybe different than some others. Some people feel that you need to get rid of parts, but we know in schema therapy that we're not really getting rid of parts. We want parts to get closer together, to have common communication, to have compassion for each other, to work as a team. And that much more closely resembles what we want for all of our patients.
Absolutely, yeah. And I think this is similar to what she was saying, but in terms of she wasn't having switching, but there was communication all the time between the system.
Yes.
Yeah,
Yes.
it was a really interesting little journey that I took there.
Yeah.
Yeah, thank you. That's a beautiful explanation. And it's interesting, I think, in some, schema therapy, multiplicity is part of the model, but in more strict CBT, for example, I don't think multiplicity has been accepted yet. But I personally find it such a useful way to work with clients, and even to think of myself and in the therapy that I have, that we do have these parts. And of course, in different models, the parts are slightly differently explained, but there's quite a lot of overlap, for example, between schema therapy modes, IFS parts, and ego state, and what's the other one? Structural dissociation. So for schema therapists working with complex trauma and DID, what are the adaptations that you recommend for working successfully with this group of people?
Well, first I'll like to just mention what's the same, because I really would like people not to feel intimidated by working with complex trauma and dissociation, to basically rest assured that a lot of your skills that you have as schema therapists are exactly what you need to work with this population. So, if you think about what we do with all of our clients, one of our goals in schema therapy is to develop a limited reparenting relationship and use that relationship to heal attachment injury, and also to start to work towards healing schemas. So, here with this population, most trauma survivors have emotional deprivation schema, mistrust and abuse schema, certainly a lot of defectiveness and shame and subjugation. At the very least, those four schemas are very strong. So one of the things that we do with all of our clients is we try to use our limited reparenting relationship to heal the schemas, to develop trust. Now we can get back to it. Trust is much more, when you talk about adaptations, trust is a much more challenging place to get to with these clients. But I guess I'll move on to the second objective, sort of an overriding objective that we have for all of our clients, is to strengthen the healthy adult and to help the healthy adult to forge compassionate, understanding relationships, not only with the vulnerable child, but especially with complex trauma, with all of the coping modes or dissociated parts, as the case may be. Because so many of these parts cause the clients and maybe therapists to feel a lot of anxiety. Parts who binge, parts that might self-harm, parts suicidal ideation. And it's so important, as you said, to respect that multiplicity and to approach all of these parts with curiosity, with an interest in attuning. And we can discuss examples later if we have time, but that's so crucial. But that's a skill that we have as schema therapists anyway, is to attune to different parts. So it's not, that part's not so different. And then I guess lastly, just to help people feel safer in their bodies and in the world by decreasing the grip the trauma has on them. And there's a lot of, when you talk about adaptation, there's a lot of different ways that we adapt trauma work, trauma memory work, to help to make it possible for people to be able to stay with us and stay in their window of tolerance and participate in the work, and not be re-traumatized, but benefit from it. But if you think of those sort of three objectives of three beacons of light that we're moving towards when we work with complex trauma and dissociative clients, almost everything we're doing is falling under one of those buckets. So whether you're handling a crisis, you're trying to build a skill in the healthy adult. Often, if the client is having a rupture with you because they've become angry with you about something, whether you've done anything wrong or not, you're repairing the limited reparenting relationship. So if you kind of keep those goals in mind, almost everything that you're doing it falls in those categories. And that sort of, I guess, centers the work a little bit.
Yeah, I think that's very calming for a lot of people to hear that. And so you're not going to have to relearn how to work with someone. But I did pick up on in there, you know, you've got the vulnerable child mode and coping modes. And I think where a lot of people who are schema therapists or have a parts model probably start to get a bit nervous is the dissociated parts, because, you know, what are they? And do we know them yet? Or does the client even have the awareness of those? So that's a little different in this presentation to a general schema therapy.
Yes, it is different. Well, even though with our other clients, they may, when they come to therapy, they may not be so aware of all of their different modes. There are modes they're ashamed of. There are modes that maybe they're intimidated by. There are modes they don't like. So that part's not so different. One of the differences with DID is that the parts are more multidimensional. So you can have a client, I'm thinking of a client I had, where there was a mode who was a part that was a binger. She also was someone with trauma memories, and she also was a caregiver for child parts. So this is a multidimensional mode. So, you know, as treatment unfolds little by little, you get to know more of the system, so to speak. You get to know more and the client gets to know more. But I think if your general attitude is that you want to bring the schema therapy attunement to every part, not prejudge, really understand, as you were saying before, why are they there? Every part's there for a reason. Every part developed for a reason. And can you put your mind into their worldview before you start trying to make changes or shut them down or push them back or do anything like that?
Yeah. I think one of the challenges I find anyway is the rejection of some parts and the client hating some parts. So, you know, I may come in, or another therapist might come in with all this curiosity and willingness to learn, and the client's like, nope. Or, you know, that part is saying, no, I'm not going to come to the meeting, or, you know, come to. So that's a significant challenge. But I do like the way that you sort of really normalize a lot of this and put it within the the frame of schema therapy. And I think that makes it less frightening for people. And because one of the challenges I find is that if people have anything going on a dissociative level, and I'm not even talking about DID, but just that they dissociate, sometimes they don't get services because they're not stable enough, or they're not this, they're not that. And so if all services and more therapists got more comfortable with dissociation and normalizing it as just a part of humanity, then more people would get access to treatment sooner.
I totally agree. Yes. Yeah, it's really sad. And again, there's so much misdiagnosis. People might be depressed as well and treated for depression, but not treated for the trauma that's underlying the depression. Not treated for all of the unmet needs that are underlying the depression. So yeah.
Yeah, that's right. And I think what I like about this approach is that it's going to stop the cycling of, say, if we see the depression as just being a side effect of all the trauma and how the system has to cope with that, then there's this way of explaining to people can provide a lot of hope. So I think someone posted into the group a video from Eleanor Rigdon about schizophrenia and voices, and tagged you in it.
I love that. Yes, I love that. It's a TED Talk. Yes,
yeah, that one. Yeah. So you know, one of the things about that is just having one person on your team who says you can get through this and it will find a way, and this isn't who you are all of the time. This is just one sort of part of you, is what I took from it. Because sometimes people with these what are called chronic or complex conditions, and even, you know, recently I had someone very despairing because they were told they had a chronic version of a mental health condition, which then they thought they're doomed forever.
Mhm.
So when you're that one person on the team that says, yeah, sure, this is challenging, but it's not all of you, and there is a way, and then I think if we can treat the trauma, those parts of you won't need to be as active.
It's so true. It's so true. I'm thinking about a client who, when we started even beginning to talk about trauma, she would say, I can feel the cutter is here. And this wasn't even a DID client. This was I would say, complex trauma client, but she knew there was a part of her who she would say, I'm seeing images of knives and sharp objects, and I'm just feeling this urge for cutting. I know my cutting part is here. So I asked to speak to the cutter part, and you're right, it's not always easy to get the parts to, whether they're dissociated or modes, they're not always easy to engage them, but this one was willing to engage. And so I spoke to her very respectfully about, how she had been with the client for a long time and what kind of situations really made her feel that she wanted to cut. And she said, well, the kids, the young ones are just crying. I just can't stand to hear them crying. And when she said that, I felt that really she had an overabundance of empathy, that she heard younger parts in despair, and she felt the need to cut, to shut. She said, when I cut, everything gets quiet.
Yeah.
So it made a lot of sense to me. Not that I, approved of her method, but it made a lot of sense to me that it was painful for her to hear all this inner pain. And so I was able to talk to her about alternatives. For example, the adult, as you described, was not maybe hateful of her younger parts, but was not particularly compassionate and nurturing towards her younger parts. But she started to see how that could be an advantage. If she could comfort her younger parts, and they're not so apt to be crying in the background, then this cutter will be less active. So, you work through the system that way.
Yeah.
But it's always good to ask and to learn. Sometimes there's real surprises.
Yeah. And I think one of the things that I've picked up along the way is the different way in which self-harm can be approached when you apply multiplicity systems point of view. And it moves totally away from, you're not cutting while you're in therapy type contracting stuff that goes on, which, tends to probably inflame the part that's doing that because they feel so misunderstood. Whereas this approach that you're talking about here is like, well, yeah, of course you've come up with this strategy because you've got no other way to cope with that crying that you're hearing. Yeah, it's really beautiful. And so, we've talked about what is the same, but now let's talk about what might have to be modified a little in terms of working with DID when you're using schema therapy.
Well, one thing is, I'd say with complex trauma and DID, I'd say, the limited reparenting relationship. I cannot overstate how difficult it is to really earn the trust of the client. And a lot of times supervisees, and I had this reaction myself initially with a client where my feeling was, but I'm so caring, I'm so sincere, I give you extra time, I care about you so much. What do you mean you don't trust me? I felt so, I think it was my emotional deprivation schema triggered. I felt misunderstood. And I see that a lot with supervisees because, if you think about it, these clients have been tricked, controlled, ignored, blamed, hurt in so many ways. Why should they really trust us? They don't have a template for people that they can trust. And so I find it's a gift if a client tells you they don't trust you. That takes a little trust to tell someone you don't trust them. So that's actually, right? So that's actually a gift. And I embrace those moments and really try to work through all of the expectations. They think you're going to be angry at them. Sometimes child parts think you're going to tell their parents on them. All kinds of different misapprehensions. And it's important to be patient. And with a DID client, sometimes half of the the system really trusts you. You've been working with a client for a long period of time, and then new parts may emerge and you have to prove yourself all over again. So I think that in terms of the basic relationship, it's very gratifying when you finally do have the trust of most or all of the system, but it's something to really have a lot of patience for and understand that it's difficult.
And it's very slow work, isn't it? I think when we live in a world where people are wanting 12-session outcomes and things like that, you know, this is just so much longer than that. And 12 sessions wouldn't even be enough to build the trust of the system for most people. So, yeah. And I think, you know, it's a really good point, because a client can go into therapy thinking they've picked a trustworthy therapist from their healthy adult mode, or maybe even one of their coping modes or managers in IFS, if you might want to call it that. But then they find they can't feel safe in the room because the other parts are saying no to that. So it's quite confusing. And I think also, you know, a lot of people want to be a good client as well.
Oh, yes.
So they won't be saying to the therapist, oh, I just don't trust you, or and I think the system often is very afraid of any poking around in it. So there's a lot of holding that through mistrust as well, just even fear of what could go wrong, because the system's formed to keep things sort of right, even though it's not always working. Yeah,
absolutely. And it's true. Very often the client presents in a very compliant, surrenderer, people-pleasing mode, but that's just the part that's coming to therapy. There's, as you say, there's so much else going on inside.
Yeah, correct.
So that's one, I guess, adaptation, and to spend just a lot more time on the relationship, a lot more time trying to establish safety if they're seeing you in person, even in your space, giving them more choices, giving them more an opportunity to have more boundaries, having them experience physical boundaries, discussing expectations, discussing previous therapy relationships, which many times, unfortunately, have been hurtful. And, you know, all putting a lot of attention into building trust and dealing with accusations, dealing with ruptures with a lot of respect and compassion. It's difficult work. You know, I've have supervisees who feel like, just yesterday I was telling someone that it seems like she's like that doll, you know, they blow up a doll that has a weight at the bottom and you push it down and it comes back up, and you push it down and it comes back up. But after a while, kind of loses some of its air, and you push it down and it just comes back up much more slowly. And I was commiserating with this supervisee who I feel that the client was just constantly having difficulties with trust with her. And I felt like the therapist was really being beaten up by it. So at least I was able to commiserate with her about that. But that, I don't know if I'd call that an adaptation. The only adaptation about that is that you do have to respect your boundaries, of course, and not overextend yourself. But I do personally find that additional contact can be very, very helpful. And with complex trauma and DID clients, allowing them to email you can be very helpful. There may be parts who are afraid to speak to you in a session who are willing to have an email correspondence with you. And that might be a good way of really getting to know the system and being available, just assessing what the needs are at any given point in time. So if you're willing and you can do it, that can be very helpful adaptation.
Yeah, it's so interesting that you mentioned that, because I know Jeff Young was very big on that in the model, and a lot of therapists do not like that aspect of schema therapy at all. And I think even many schema therapists don't do that part. And it is hard because, you know, you've got a personal life, and I think many of us are probably carrying a lot more clients than is probably good for us. So, you know, sometimes having those messages arriving on a weekend and things like that's not really ideal. But one thing I find is that only certain parts will email you, though. Like, it's in the experiences that I've had too, you'll get certain communications, but also sometimes it's quite helpful because it's been clear to me that the client hasn't remembered what's happened in the session, because I'll get a repeat of something that's happened in the session come in the email as if it's never happened, you know. So
Well, that's interesting.
so
Yeah.
if you can allow a little bit of that, it does give you a greater insight into the what's happening, how much of the session, you know, perhaps the part that you're talking to now wasn't actually present for the session. So
That's right.
it's very complicated. Who was I actually with?
Yeah, it's complicated, but it can be helpful. It can be very
Yeah.
helpful. I'd say another adaptation. Oh, did you have something else to say about that?
You go with you next.
Another adaptation that I think is really important to talk about is the actual working with trauma. I mean, for one thing, I would not rush it. I really like to work on building the healthy adult up and helping the healthy adult to have some kind of understanding and degree of compassion for their parts. And for me to feel that I have some attachment and connection with many of the parts, if possible, before getting into trauma memories. It's not always possible to hold off on that. But one of the things that I have presented in workshops is what I like to call my titration menu. I call it. And a lot of it has been assembled from various sources in the trauma community and the schema therapy community, just different ways to make the work safer. Everything from distancing techniques to Rick Clough calls it fractionation, where you're just working with a little bit, an aspect of the trauma, whether it's something you hear or something you see or something you smell. Or Peter Levine talks about pendulation. So where you spend a little time with the trauma, close it down, come back to some discussion that helps the person stay grounded in their healthy adult. And so I've kind of put my own spin on some of these things as I've experimented with them and used them with clients, but it's incredibly useful to learn some of those adaptations.
Yeah. The menu is great. I've got my copy of it from the training that I did with you. So thank you for that. And you're right, it does, if people have worked or trained in complex trauma or, you know, even EMDR, if you're trained with Dolores Mascara or something, you'll recognize these techniques. They're not new, but I guess Robin just has a way of explaining how we would do that with the processing tools that we have. And, you know, because one of the things with imagery rescripting, for example, which would be one of our major tools, it's just going to flood someone with a complex system if you kind of suspend them in that image as their vulnerable child back in time without using one of the items from the menu. It has been my experience anyway. And I sometimes say to people, if your imagery rescripting has gone completely off the rails in that it was very unpleasant for the client and for you, or it's just never feeling good when it ends, there's probably some aspect of that menu that you need to apply to make that safer, because otherwise we can re-traumatize people with imagery rescripting.
Yes. And for each client, sometimes even different parts of the client respond better to different techniques. I forget who it was, maybe it was Irvin Yalom, who said that we develop a new therapy for every client. But in a way, it's good to have these various tools so that we can collaboratively with the client figure out, well, would it feel better for you if we kind of did it this way? Yeah, I think it might. Okay, so let's try that. And it's a lot of trial and error, but you want the client to feel right, to not be in a puddle at your feet at the end of the imagery. You want to be able to do imagery, but you want it to have it. You want them to, at the end of it, feel strengthened, feel better about themselves, feel safer, you know, all of the goals that we have for them, rather than feel overwhelmed. So
so all of these techniques on your menu are just a really good way of helping that happen for clients who are not having that experience with just a general formulaic imagery script. What would I call it? Well, the scripts that we get given when we're trained in it. So I just think that's very important, because it's very hard. It doesn't matter. It's not just imagery scripting. So it happens with EMDR processing as well. And I'm sure the other methods, that if it's too overwhelming and big, you'll struggle to get someone to do it again. And so that's why these titration techniques are so great, because if people have safer and more helpful experiences, then they'll agree to do more trauma processing.
Yes.
But of course, you know, all parts of the client may be saying, never again, I will not be doing that. And then, you know, you get a bit limited in what you can offer people. So, and I'm not to judge people who that's happened to, because I've certainly been the therapist who let that happen. But once you know about this, you can do things differently. And you can also revisit with clients, say, hey, I know that didn't go so great, but how about if we try it this way? Because that feels tolerable.
Right, exactly.
Yeah.
And actually, one thing that I don't think was on the menu, which is an additional technique that you can use if you're working specifically with a DID client, is that sometimes using the client's ability to dissociate and separate can actually be very helpful, not only with trauma memories, but with memories, you can choose who you want to work with. There may be a part or two parts who share a memory. And because of the dissociative barriers, you can ask that everyone else go away into a safe place inside, maybe have caregiver parts with child parts, and only work with the parts who have the memories. So it really keeps the system from being overwhelmed.
Yeah.
You're working with the ones who directly need the work and are ready for the work. And it has even there too, you might use titration, but it has a much better chance of success. And then when those parts feel better, the whole system just feels more at peace, even though they may never learn the content of those particular memories.
Yeah. And certainly that's something that other people I've talked to about DID say is very helpful as well. And that's when you've really embraced that idea of multiplicity. I think that actually I could just treat that part. I don't have to have the whole system present. And although I think, you know, some people would say you have to get consent from the system to move into the safe container, and that in itself can be hard work to get certain parts to say, yes, okay, I won't be here. Because if their job is to sort of protect and do all that stuff, they'll need a little convincing.
Exactly. But that's why it's really good to forge those relationships with different parts to begin with, so that they're willing to at least give you enough trust to know that you're trying to work in a way that does no damage and that can actually help. And maybe it's a leap of faith for them, but yes, you definitely have to get consent. Absolutely. But you can do other things with DID clients, which also involve voluntary, who's going to be with you and who's not going to be with you. With one client that I had, we regularly held groups. We had a few parts of the client who were bingers. So we had a binge eating group. We had only those parts would come together and take turns with who was out front in any particular meeting. And they would discuss strategies with me, and they would discuss situations which made them binge. And we had a name for our group. No Blame, No Shame was the name of the binge eating group. The same client also had a few adult parts who felt to themselves to be part of the marriage. This person had a husband. So we had the married group. And when there were issues with the husband, I could meet with the married group and we would talk about communication strategies and how to work with him. So there are a lot of things that you can do with a DID client that are a little bit maybe even harder to do with a complex trauma client without DID.
Right. Yeah, that's quite interesting. And it's, I think it's just a great example of how creative you've become with this whole theory and how you're applying it. And one question I do have, in Schema therapy, there is ideas around the punitive critic, which are quite different to how other parts models would approach it. Do you find with DID there has to be some adaptation around how we work with punitive critic parts?
Yes. The ones that I've come across have been, in some ways, an overcompensation against feeling total vulnerability and weakness. These are parts who felt that in life you either have to be the abuser or the abused. And even though many parts of the client have been the abused, they've decided that they're going to identify with the abuser and be the abuser. So even those parts, I find that, and you're right, they're not always thrilled to speak with you and engage with you right away. One client, that part came out and said, "You have 5 minutes." So he was sort of a king. He was a king on a throne who deigned to give me 5 minutes of his very busy time. And we managed to have several meetings in which he gave me 5 minutes. And lo and behold, this particular punitive critic was someone who had actually experienced the very worst of the abuse and had just internalized some of the beliefs of the abusers. So combination of psychoeducation, modeling my relationship with him, because I was a model of someone who was strong. I wasn't abused. I was strong. I was not afraid of him, but I didn't feel the need to punish. So over time, he was able to learn a little bit from me. And basically, to give you a very long answer to your question, very often these parts can modify their behaviors over time, and they can modify their thought process over time. And with this particular client, the part became a very helpful, strong internal protector. So, I believe not to go into any of these parts, however disagreeable their initial presentation is with any preconceptions, but really try to get to know them.
Yeah, and I think that conceptualization of it as probably some sort of fighting or protective role in the system, rather than a part that we're trying to cut out or get rid of, or throw a chair out of a room or something like that. I mean, I think this is when I started to think, oh, hang on a minute, some things aren't going to be different, because if I sort of had a strong word with a punitive critic mode, all hell would break loose for this particular client, and it was actually hurting them. And so really it's about trying to understand the role that punitive part is playing in the system, and seeing if you can shift, and then hopefully shift those negative beliefs that they've held on to, usually from very, very young. That's what I've found anyway, that these messages.
Definitely.
Yeah.
Right. Sometimes sometimes you're having a strong word with them, but it's more like a debate, or it's setting them straight about something that they're believing. But you're right. But you're right. You might be having a strong word, but not a word where you're telling them to leave the system or
or that they're not really a part of that person, because they will fight that back very, very strongly. And it's just hard as a therapist, I think, when you first come across parts like that, because you can see the damage that they're doing to the child parts and the person's ability to function often.
Yeah, so, and they're intimidating. They're intimidating to therapists as well.
Yeah, they can be. So thank you for sharing your thoughts about that. And I was thinking if there's anything else that you wanted to cover, or I've checked. I don't think anyone's popped any questions in live, but anything that you can think of, Robin?
I don't know. Are there any other examples that you're interested in, or aspects of different adaptations to working with GID clients? I guess I could say a little bit more about that.
Well, I wondered, you did mention that you've done the internal family systems training, or at least some of it. The more I look at that, there's all these levels and things that they get involved in. I'm just wondering if there were parts of IFS that you find useful to blend through in this schema therapy adaptation, that or any of the techniques particularly.
Yeah, I think in terms of imagery rescripting, I think probably, just as I said that I've taken in a lot of different titration techniques and given them my own spin or flavor, I think in terms of the IFS techniques, one of the aspects that I brought into, I guess, imagery rescripting is really helpful when a client, as you mentioned before, is very hateful or blaming of their own younger self, which is very common. So I think and it's so funny because sometimes my IFS work is blended in. I'm not exactly sure where one thing begins and the other ends. But just the idea of having them, asking them when they step back from this younger part, how do they feel towards that part? That's, I think, was initially an IFS question that we were taught, which is very helpful. And then helping them to take judgmental parts, put them aside, and try to look at the younger part with an open mind. And then if they can view the memory from a distance, then we can get into more of a titrated imagery rescripting, where the client is viewing the younger part in a memory, in a scene. And one technique that I like is freezing the scene, asking the young child, to look up and look into the eyes of the adult client. And so often that's really so helpful in terms of changing their feeling towards the child, because they have these sort of self-blaming versions of the memory story that they've been carrying around for 20, 30, 40 years. And then to be able to somehow see the child from a distance and say, she's so confused, or, oh, she looks so frightened. She doesn't really want to do that. Why did I think she wanted to do that? She didn't want to do that. It really can change so much. So it impacts the imagery rescripting, is impacted by those kinds of things. I'm not even sure if that's directly IFS. I think it's maybe a little bit influenced by that, but it's just something that's
I think there is something across all the models. There is a little bit of similarity. I mean, we're dealing with humans.
So much overlap.
But I think one thing that I've found useful from the IFS is the age orientation emphasis, not only just about how old is the child part, say, in imagery, but the part of you that the mode, for example, that's doing this, how old does it think you are? And how old do you feel when you're in that mode? And often that's really young. Like someone I was working with yesterday had some career issues, and the part of her that's convinced she can't do it really feels 8 years old. And I was like, well, I agree with you. You can't do that if you're 8. You would not.
Exactly.
The part of you that needs to do this, how old are they really? And then, we talked about that age, and it's an entirely appropriate age to take on those sort of leadership roles and things like that. But that I find quite useful. But yeah, and I think I was actually reading the No Bad Parts book a while back, and Dick Swartz did start with chair work and things like that too, but it's really become a lot of imagery type work, recognizing you can go in the parts without actually having to move, whereas I think in schema therapy there's still a bigger emphasis on diffusion through movement. But I think it's great to know what's possible, because for different clients different things that can be better. So for some chairs will be better, and for others just moving internally between parts is possible as well. So
I totally agree. Yes, it's so individual. And with DID clients, I find the chairs are less necessary. They're just so used to the whole switching that you can just say, now I want to speak to this part, or can I please speak to that part? Or they'll say so-and-so wants to speak to you, and they have their own way of just bringing that part forward. So it's not as necessary.
It's interesting that you say that, actually, because one training I went to, it was with Kathy Steele and Dolores Mosquera, and they were very anti the putting DID parts into chairs, because they said we're aiming for integration. We don't want further separateness. And when I thought about it, that makes a lot of sense, actually, because if you're kind of really embodying these parts even further, if it's just a mode, then that's okay, because you're getting a bit of embodiment so people can understand the differences and connect that in the outside world. But these people don't really need that, because they've already switching quite completely, and that's probably not always helpful. So yeah, it's I think probably what we've talked about today is that schema therapy has a lot of foundational things that can really help with this, but there are probably some thinking from other models with multiplicity that can really help for different clients that you will come across with DID. So it's been such an interesting conversation. I just thought we should finish up with talking about what's coming up for you in terms of your offerings next year, or anything that's currently available to buy on replay now. Did you want to share with the audience?
Well, the workshop that you mentioned that Judy Margolin, Megan Fry, and I put together in last year, 2021, I believe is still available for sale. If anyone else who's watching today is interested in finding out about that. Megan had taken care of our marketing, so I think that would be the best bet, would be to reach out to her. And I have workshops. I have workshops in my mind. I don't have anything specifically planned and scheduled at this moment. And as I said to you before we were on camera, I just love my supervision groups. I really enjoy helping people struggle with all the complexities of these very challenging clients, and kind of feeling that we're carrying them together in the group so that no one's alone with these very difficult clients. So I have some supervision groups that are specifically geared to DID, and I have other supervision groups that are covering the whole spectrum of trauma, everything from traumatic grief to single episode traumas to developmental traumas, not necessarily, including dissociative disorders, but not necessarily dissociative disorders. So
those will be coming as per usual, and I have seen you advertise them through Schema Therapy Made Simple, which is great. So hopefully you'll continue to do that. And I guess if people are on the list, so they can find it there. And for those of you who are interested in the complex trauma and DID training, and this is a really great training, Megan Fry's got a website with contact details. I'm not sure if there's a store on there, but anyway, I'm sure she'll be happy to point you in the right direction so that you can access the really fantastic training that Rob and Judy and Megan put together. So thank you so much, Robin. It's been an absolute delight to have you here to talk about something that's really interesting and also very important, I think, to get into the mainstream so that people can start looking for how to help these types of clients better, but also just recognizing that not all clients are ready to share that. So if we as therapists can start to look for where it might be, and then work with dissociation more, and provide psychoeducation about that, then our clients are just going to have a better experience of therapy. So thank you, Robin. It's just been wonderful.
You're very welcome. It's been a pleasure. Thank you so much.
Okay, so we'll come off the live stream. We'll just have a quick chat. So goodbye, everyone. And